Hi, good afternoon, everybody, and welcome to this month's VAM Lunchtime webinar. This is our third event in the series, and we're aiming to bring you concise, accessible talks from across the violence, abuse, and mental health sector. We have a great programme of speakers across the year, and today I'm absolutely delighted to be welcoming Katherine Dean and Emma Clark from Women's Aid. If you're here today, hopefully you already know all about the Violence, Abuse and Mental Health Network. In case you got forwarded the link and you don't know who we are just yet, we are a network of researchers, practitioners, policymakers, and members of the public who are interested to understand, reduce, and prevent the impact of violence, abuse on mental health. And one of the key ways we do that is by coming together to share knowledge and latest research and analysis on those topics. Hence our webinar series. So in today's talk, and Flavia, if you could bring the slides up, please, that would be super. We'll be outlining the key findings from Women's Aid research on domestic abuse and mental health. And this will include Katherine and Emma talking through the latest annual audit report, which brings together the most comprehensive set of data on domestic abuse and service provision in the country. The data includes the on-track national data set looking at survivor experiences, the annual survey, which explores the state of the sector with local service providers and information from local authorities commissioning trends. And Katherine and Emma will be discussing the need for mental health service provision, the national picture of mental health and domestic abuse service provision, and the outcomes of support which survivors access around mental health. So absolutely superb and so relevant to our collective interests. Emma and Katherine will be talking for around 20 to 25 minutes, after which we will have time for questions. We have this set up as a webinar rather than a meeting, so you are all muted and videos off. If I can ask you please to use the chat to introduce yourselves and to put share any resources or link out to anything that you'd like to share with other attendees, that would be super. And any questions that you would like me to put to Emma and Katherine at the end of their presentation, if you could please put that in the Q&A box, that makes it much easier for me to make sure I can see everything that's coming through. I will hand over to our speakers. Thank you so much for joining us. We're delighted to have you here today.
Thank you very much, Shan, and thank you everybody for coming along today. My name is Emma. I'm going to begin the presentation by introducing you to some of Women's Aid's national data sets, and then talking through some of the key findings on mental health from the on-track national data set, before handing over to Katherine, who's going to speak through domestic abuse support services and mental health from the annual audit. And then, as Shan mentioned, we'll have the Q&A at the end. But first, just some background about Women's Aid. So Women's Aid is a national charity which is working to end domestic abuse against women and their children. We're a federation organisation of just under 170 local services who provide 300 local life-saving services to women and their children across the country. At Women's Aid, we work to support our member services and survivors in a variety of ways, and this includes our direct services team who work directly with survivors through the live chat and survivors forum. We've also got our national campaigning work and our national training centre, and of course through our research as well. Next slide, please. So to introduce you to Women's Aid's three main national data sets, we've first got On Track. And On Track is Women's Aid's bespoke case management and outcomes monitoring system. The system is currently used by just over 100 local domestic abuse services. And where services and survivors consent, the data collected through their daily work with survivors feeds into an anonymous data set which is held by Women's Aid. The data set currently holds information on just over 200,000 survivors accessing services, which makes it the largest data set in the country looking at the experiences of survivors accessing support services. Next, we've got Routes to Support, and Routes to Support is the UK Violence Against Women and Girls Directory of Services and Refuge Vacancies, where services can access up-to-date information and local services and refuge vacancies. And then through this, we collect the Routes to Support database, and we can access information on the level of service provision, including specialist services and refuge vacancies across England. And finally, we have the annual survey, which is an online survey which we send round to refuge and community-based services for female victims. And the survey collects information on the challenges and successes that those services have faced. And these three national data sets we report on annually in our annual audits, and they provide a picture of current levels of domestic abuse service provision and also the women accessing these services. Next slide, please. Before we get into the data, I also wanted to bring your attention to our Deserve to be Heard campaign. And this was a campaign launched in 2021, which was calling for greater recognition of the impact of domestic abuse on the mental health of women and their children. We don't have too much time to go into all of these in too much detail today, but would really recommend going to have a look at the 4 key research reports that we published during this campaign. And they include a guide for survivors who are struggling with their mental health after experiencing domestic abuse. There's also a qualitative piece of research called Are You Listening?, which includes interviews with survivors, asking them what they are looking for from their mental health support. And we also published 2 literature reviews as well, which present an overview of available evidence around domestic abuse, mental health and trauma in the UK. And one of these is specifically looking at the experiences of Black and minoritised women. Next slide, please. So now I'm going to move on to talk through some of the key findings on mental health from the On Track national data set. Next slide, please. Thank you. So every year from the On Track national data set, we report on the number of women who access services who use the On Track system. And in 2022 to 2023, there were 3,700 women who accessed refuge and 36,500 women who accessed community-based services, whose experiences were recorded in the On Track national data set. So on the slide here, we can see some of the data around their mental health. So in refuge, there was 23.4% of women had a mental health disability, and this was 21.2% in community-based services. And this was the most commonly reported type of disability. Out of a subsample of women who reported having a disability, mental health was 69.9% out of that subsample. We also saw that half of women in refuge had a mental health support need, and this was slightly lower in community-based services at 41.5%. Also in refuge, 10% of women and 6% in community-based service had a dual diagnosis, which is when someone has a mental health support need and a drug and alcohol support need. And then we can see some of the impacts of these mental health conditions and the impacts of the abuse. So in refuge, 47.4%, and in community-based, 33.4%, reported experiencing feeling depressed or having suicidal thoughts. And in refuge, 10%, and community-based, 5% of women reported self-harming as a way of coping with the abuse. So we can see from the On Track data the significant and long-lasting impacts that abuse has on survivors' mental health, and as well as the huge need for specialist mental health support to be provided to survivors who are recovering from abuse. But also from On Track data, we can see that current levels of service provision aren't always able to keep up with this need. So for the same financial year between 2022 and 2023, we've released a new On Track data briefing, which looks at the reasons for unsuccessful referrals into refuge, so when the service has to reject a referral for a survivor. And we saw that the most commonly reported reason for rejection was that the service didn't have the capacity to support the client. And nearly half of these were because the service didn't have the capacity to meet the specific support need of that client. And mental health was one of the most commonly cited support needs that services did not have the capacity to support at that time. And this made up nearly 5% of all unsuccessful referrals. So to talk in more detail about mental health and service provision, I'm going to pass it over to Katherine now.
Thanks, Emma. If I get the next slide. And the next slide again, please. Thank you. Hi, everyone. So my name is Katherine Dean. I'm the Senior Research and Policy Officer here at Women's Aid. I work across a few different areas of our research and policy priorities, but the main sort of focus of my work is around the annual audit, which Emma has explained is our yearly kind of summary snapshot of demand and provision for domestic abuse services in England. So I'm going to be drawing on some of the findings from last year's report, the annual audit 2024, but also on the Deserve to be Heard project that Emma mentioned. So every year, the audit shows us that specialist domestic abuse services are keeping the community safe and are also identifying gaps in support for survivors, and more often than not, they are filling those gaps. So increased pressure to support survivors with their mental health needs has been a really key challenge for domestic abuse and VAWG organisations over the past year. And services anecdotally have reported that they are finding that more survivors than ever before are presenting with complex needs such as mental health, which are including but not exclusive to post-traumatic stress disorder. So as I'm sure you all know, access to suitable mental health support, such as statutory support, is frequently delayed and with extremely long waiting lists. And this can really delay recovery for survivors, especially. This can be particularly challenging for survivors whose first language is not English, as finding counsellors who speak the same language can be even more limited. Services also found that clients sometimes miss their appointments with domestic abuse support workers due to mental health crisis episodes. And of course, another sort of knock-on effect of that is that it can increase and delay the caseloads for services who are supporting survivors more generally. At the same time, finding move-on accommodation has also been increasingly challenging over the past year. And what that means is that poor mental health of survivors can sometimes be exacerbated by longer stays in refuge, which can lead to poor mental health outcomes for survivors overall, as they can't access the services and move on accommodation that they need. Next slide, please. Yeah, so as part of the Deserve to be Heard campaign, I just wanted to touch on this because survivors have really emphasised the need for specialist mental health support and how without it, survivors could be re-traumatised. So as part of this campaign's research, there are just a couple of quotes that I wanted to share with you. One was from a survey respondent who emphasised how mental health professionals really need to, and I quote, have specialist in-depth knowledge as their actions can cause further harm, thereby adding to traumatic experience. And the second quote is from a survivor who was taking part in a focus group. And they said, if they, professionals, don't have any experience, that's when they can do more damage than good if they just think that they can do it, i.e. if they don't have any specialist domestic abuse training. Next slide, please. Thank you. So ultimately, as part of last year's annual audit, services told us that it's themselves who are needing to fill these gaps. So over the past financial year, the domestic abuse and wider VAWG sector have worked to fill these gaps and also to reach more survivors as well. So to give some examples of this, 44% of the organisations who responded to the 2023 annual survey reported that they had been providing a service that they felt should be covered by a statutory agency under a public statutory duty. And of these, over a quarter, so 26%, were providing that support was a mental health support or counselling. At the same time, around half, so 49% of organisations reported that they'd been running an area of their domestic abuse service last year without any dedicated funding. When we asked what areas these were, the most common area that was working without dedicated funding was therapeutic support services, so counselling and group work, and 43% of those who were running a service without dedicated funding selected this option. Meanwhile, also 16% told us that they were running specialist domestic abuse services for women with complex needs without any dedicated funding. I wanted to just finish before handing back to Emma with some data from Roots to Support around current provision levels. So there has been a small increase overall in the number of community-based support services that have mental health specialist workers over the past year, but there's not been any change over the past year in terms of refuge services as on Roots to Support. So in May 2023, there were 39 community-based support services in England that had specialist mental health support workers, and that's an increase of 4 since the last year. But there hadn't been an increase over the last year in refuges, and those 48 refuges had specialist mental health support workers. So I will hand over back to Emma there.
Thanks, Katherine. So what's next? What does all this data mean? So to ensure that survivors have access to the mental health support that they need, we are continuing to call on the government to invest £516 million per year to fund specialist women-led by and for domestic abuse services in England. And the reason for this is we know that specialist services are best placed to support survivors with their mental health. So from On Track data, we saw that 51% of women leaving refuge reported having positive mental health outcomes. And this includes around improving coping strategies and accessing mental health treatment. And we also know that specialist services are what survivors are looking for from their mental health support. So from the Are You Listening research as part of the Deserve to Be Heard campaign, survivors put together 7 pillars of mental health support to meet their needs. And we can see there number 6, this includes women-only spaces, including support led by and for marginalised groups of women. And number 5 there also includes practical support, so ensuring that where survivors are receiving mental health, they're also able to receive more holistic support as well, which is what specialist services are there to provide alongside.
We also have some asks from our national campaigning that we think are really important. So there's 3 of those. The first one is we'd really like to see more funding for integrated care boards to fulfil their duty to meet the needs of survivors and to collaborate in the commissioning of evidence-based domestic abuse interventions in health settings. So that includes IRIS, RIIS in GPs, surgeries, as well as IDVAs and other specialist advocates in acute hospital and maternity services. Secondary, we need mandatory specialist and continuous domestic abuse training for all healthcare professionals. That training should cover how to spot the signs of domestic abuse, as well as how it affects mental health of survivors, as well as the additional challenges that are so often faced by Black and minoritized women. And our third ask is around health bodies need to commission needs-led mental health support services for survivors, and those to be delivered by local specialist domestic abuse services to ensure that any mental health strategies include actions that address the specific mental health needs of domestic abuse survivors. So next slide, please, and I'll just pass back over to Emma.
Thanks. So all the research we've talked through today can be found on the Our Research section of our website, which I've linked there. So you can access our annual audit reports, the Deserve to be Heard research reports, as well as the on-track briefings. Would also recommend having a look at the Nowhere to Turn reports, and these are the annual reports from our No Woman Turned Away project, which also talk about mental health barriers that women face when accessing services. There's also our Invest to Save report, which explains that £516 million per year figure in more detail. And if you want to contact us or have any further questions after today's webinar, our email addresses are on screen there. So it's ontrack@womensaid or researchandpolicy@womensaid.org.uk. And you can also find us on our social media platforms, which are linked there on the slide as well. So thank you very much, and looking forward to hear your questions next.
Thank you both so much, Emma and Katherine. That was such a clear but detailed presentation and had such a wealth of information in it. So thank you. It's a difficult one to hear, isn't it? Where you're really talking about this context of increased complexity and reduced funding and so much need there. People who are on the call, please do submit your questions through the Q&A box. I wondered whether I could just take you back to towards the beginning of your presentation when you were describing those prevalence statistics on the level of the prevalence of mental health disability and support need. And I wonder if you could say a little bit more about what types of need you're seeing coming through the people in contact with the refuge and the community-based services.
So from the on-track data, we don't tend to get much more detail than just whether there's a mental health support need or a mental health disability there. We do collect information on experiences of abuse, which has a bit of crossover, which is what was presented there. So those are the two main fields that we collect information on, which include self-harm and feeling depressed or suicidal. The system isn't sort of set up to get those sort of more detailed responses, but as Katherine sort of talked through, I think from the annual survey and through the Deserve to be Heard research, I think it's a lot of complex PTSD and suicidal ideation, I think, are probably the most prevalent. Katherine, I don't know if you've got anything to add on that.
Yeah, no, just to reiterate that essentially, I think from our data collection perspective, it's more anecdotal in terms of the kind of specific needs that are coming through. But that is something that we can look at on track as well, that we can try and kind of get a bit more detail around that. But yeah.
Thank you. And are you able to say a little bit about how you measure improvements in outcomes?
Yeah, so as part of the on-track system, services can access an enhanced exit assessment. So every time a client leaves their service and they close the case on the system, they have an exit form which they can complete to sort of select all the outcomes that that client sort of had when they were leaving the service. So this is mainly a form that's kind of just has tick boxes at the moment. So that was one of where that data comes from. So when the cases are closed, and then those forms we get sort of like the aggregated data from. So yeah, that's how we measure those outcomes.
That would be a client self-reported improvement in outcomes or a caseworker assessed.
It's usually a caseworker assessment. I think because it sort of just depends on how the service, I'm sure each service will sort of use the system slightly differently. So there might be some cases where the key worker will go through it with the survivor, but I would say normally it is just the key worker completing it. We do also have power forms, which services use quite frequently, but we weren't able to present the data today, but those they measure sort of changes in the survivors' personal well-being over time throughout their time in service. So sort of collecting data around feelings of safety, things like that. And particularly in refuge, that's one of the findings we see quite frequently from those power forms, is the feelings of safety just sort of skyrocket from between that initial assessment and the final assessment when the survivor's leaving the service. We'll hopefully be able to publish some more data on the power forms, because it is some really valuable data.
Thank you. Also, I've got questions coming in thick and fast on the Q&A, so we will try and get through as many of them as we have time for. Anything that we don't get through, I will share with Katherine and Emma and see if that's something that they're able to address offline, and then we can share after the event. Obviously, I'm very conscious of their time and their responsibilities outside of this talk, and so that that may be a delay or not possible, but we'll all try our best on that. So a question. I'm surprised by the figure for the number of refuges with mental health, with specialist workers. It seems quite high. Is any guidance given when collecting this data on what counts as a mental health specialist worker? And can you speak to what roles might count as this, please?
Yeah, I think that's a really good question. So that data is all taken from our Routes to Support platform, which is actually our sort of third colleague, Maya, who works mainly on that. So in terms of the definitions that she uses when she collects that, then we'd have to revert back to her. But it's very much standardized in terms of when people are inputting their data onto Routes to Support. That's not something that's come from the annual survey or has sort of ambiguity in like that. So yeah, we could definitely take that one away, I think, and send back some definitions if that would be helpful for that person.
Thank you. Several questions coming through about NHS. So are there any identified barriers that NHS partners are seeing to addressing these findings?
It's a very good question. I mean, I anecdotally from the annual survey, I think that things that people are really finding is around obviously capacity and fitting those kind of questions into an environment which is already working at maximum capacity, essentially. I think something that we have also found in the annual survey that we didn't necessarily talk about in our presentation, but I think is really important, is the sort of correlation with increases in the cost of living and the impact that that's had as well on the well-being of survivors. In the annual audit, we had some data around, I think it was about 73% of survivors are finding that the cost of living was having a negative impact on their well-being and health. And again, all of these factors are influencing the sort of the space and the parameters that we have for working with partners. But yeah, from our side, I think it's about continuing that national campaigning and putting forth the importance of these things and making sure that training is mandatory at all levels within the NHS and within healthcare professionals.
Thank you. Relatedly, somebody has asked, NHS trusts have internal domestic abuse training. Are you involved in any work around the formulation of that training or the evaluation of that training?
That's one that I probably need to go back and ask the team. We have specific work that we do around integrated care boards and the funding side of things, but I'd have to go back and double check with the training team, unless Emma, you've got any.
No, I'm not aware of anything at the moment. I have to go and double check that.
Sticking with NHS, we've heard that mental health services sometimes reject or redirect referrals for survivors of domestic abuse back to domestic abuse services due to a lack of specialism or confidence in supporting someone with experience of domestic abuse. Are there practical partnership steps we can take to build capacity in both mental health services and domestic abuse services to ensure survivors are getting the support that they need? Definitely.
In summary, I think, as I say, that's sort of part of our work with ICBs and with also local authorities at the moment. I think that would be something that actually the policy team would be really keen to pick up and talk a little bit more about those partnerships on a local level, because I think a lot of these we work on a local level. Yeah, to make sure that those those pathways are happening in a sort of systemic way rather than people being moved around so much. But that does also really relate to that point around increased complexity and also increased demand that we're really finding this year. And I think from our side, we're currently looking at the results of next year's annual survey, and those issues around complexity and whose responsibility and who feels most confident, I think, to deliver those services is really coming up again. And it just relates to that point around the fact that mandatory training needs to be done at all levels, and specialist domestic abuse services need to be involved from the early stages.
We have seen in many settings the co-location of independent domestic abuse advocates in health services can have some can really help in improving outcomes. Is that something that you would see as part of the way forward?
Yeah, absolutely. Yeah, absolutely. I think the more that there's those kind of co-locating or those partnerships happening at each level, I think that would be definitely part of the solution.
Picking up on what you mentioned previously about policy, so a question, I'm interested in more detail on how Women's Aid research findings support and inform the national campaigning and policy work and the traction that this results in. An interest in the how this works.
Yeah, definitely. So I mean, on a practical level, we have different research projects we work throughout the year. The annual audit is one that we have done for many years now, and I think that's the best sort of location for any new trends that are kind of coming in, or to talk about the ways that the sector is changing, the specific troubles that people are finding. Within that, we share that with policymakers at various different levels. We have various different formats of those findings as well that we can relate to people. But the policy team works specifically, as I say, also on local influencing, and I think that's a really big part of our work as well, which would be something that we'd be able to support with. But if they had a specific policy interest or area of concern that they wanted to kind of raise to us, I'd really encourage them to email the research and policy inbox, and we'd be able to set that up.
Thank you. Are there areas that you are thinking we haven't got that data yet, we haven't got that evidence yet, but we would really like to be able to have that either for a service or for an advocacy purpose?
I think from an on-track perspective, I think we would like to be able to collect more data around the sort of specific support needs and then how these directly map onto outcomes, because I think then we'd be able to sort of evidence differences between maybe different groups of survivors and how it particularly affects Black and minoritized women, or sort of, for example, like women with drug and alcohol support needs. I think yeah, being able to directly link those support needs to outcomes would be definitely an area of interest for us.
And sorry, another question for me is that difficult for me to keep track with all of these questions that are coming through, and they're all great. Do you see, I'm trying to group them by theme, but I'm thinking I'm not doing possibly as good a job as I might. Do you see different rates of mental health support need or disability reported when you disaggregate by the type of abuse?
Yeah, that's a great question, and it's not something that we've been able to put a lot of resources to research in just yet, but it is definitely something that is on our radar. We've recently just updated the way the system collects information on experiences of abuse, which allows services to record a much sort of deeper level of information. And I think once that's been up on the system and we've been collecting data around that, we usually sort of leave it a year so that we've got like a bigger cohort of data to be able to analyse. That's definitely on our radar, to be able to have a look at the different experiences between different types of support needs and how they vary. So not a huge amount of information on that at the moment, but definitely something we're working on.
Thank you. That would be really interesting to see what does come out of your data. I'm just kind of reflecting on the existing academic literature and the types of things that are reported there. Obviously, there are gaps. We do see across sexual violence, physical violence, coercive control, we see very high levels of depression, anxiety, and PTSD. Those tend to be the three that get asked about primarily within mental health research. When we look at the other side, at people in contact with mental health services and look at their experiences of domestic and sexual violence, we see very high levels of domestic and sexual violence across a range of different mental disorders. And so I would expect that you would see high levels across all of the abuse types that you looked at. But it'd be really interesting to see that, and also to see whether and how that patterns differently across your refuge-based and community-based support, and also what's showing up where in terms of who you're able to take on and support, and who you're not able to kind of manage the complexity. Can I ask whether you see regional variations in the extent to which you're able to work with mental health services to support survivors to get the support that they need?
So from on-track data, there does tend to be some regional variation. I think this would probably need to be investigated in a bit more detail, though, because it does, obviously, because it's administrative data from the services, it sort of does depend quite heavily on where services are located in the data set. So we don't have a sort of equal spread of the number of services across the different regions. So sometimes that can lead to the data, when we look at it regionally, being a bit skewed. I can't remember off the top of my head, but I probably wouldn't want to share those findings just yet, because they, like we said, they need to be a bit more investigated.
And we've spoken about difficulties accessing secondary mental health and waiting lists for mental health support. Are you encountering problems supporting people to access care through GP services also?
Through GP services, I'm not quite able to comment on that, but certainly we're having problems across the board. I think every service is having increased demand in general at the moment, across every different area, whether that's mental health support needs or any other support needs. And that's something we're really trying to track, I think, this year as well with the next annual audit. We're trying to sort of put a bit of a baseline, I think, at the moment of what services, what the provision is, and then from that, comparing each year on how that's improved or hopefully not worsened. But yeah, I don't know if Emma as well has anything.
No, not from our end. We don't, because obviously the data is just looking at services experience with the specialist domestic abuse service. We don't tend to get a lot of data around GP services from the on-track study.
And I wonder if you just, in there, we've got a few minutes left. I know one of the kind of the key calls is that health bodies should commission needs-led mental health support for survivors delivered by local specialist domestic abuse services. And if you could say a little bit more about, about that and what we would like to see in place and what that would look like and mean on the ground.
Yeah, absolutely. I think it relates back to this point of the worst possible scenario is doing more harm than good. And I think if without that specialist abuse, domestic abuse involvement, I think we have heard from survivors that things can ultimately worsen. I think that when someone has a negative experience with any kind of statutory agency, whether that's police or health, I think that can really affect things long term. And sort of, that negative capture side is really important. What we're saying is that we have to have the funding behind that, and domestic abuse services are already filling those gaps and already seeing the issues and trying to fill them as best they can, but they have to do that with funding. It's just not going to be sustainable long term. And part of that is the role of ICBs, and part of that is more generally. But I think as much as we can kind of have a collective voice on these issues, whether that's someone who's working within domestic abuse or health or in academia, I think that sort of collective voice is really, really important on that.
Fantastic. Katherine and Emma, thank you so much for joining us today, for sharing the insights from those fantastic data sets that you have, and for putting them in that real world context. It's so valuable. Lots of people have been asking whether the recording is being made available, whether the slides are being made available. The answer is yes to both of those things, happily. So the recording and a PDF of the slides will be appearing on the VAMHN website in the next week or so, and we shall send an email with a link to where you can find them to all of the registered attendees today. Thank you very much, everybody who has joined us on the call. It's really great to have the opportunity to share these findings and insights across such a range of professionals and sectors, and we really are grateful for your attendance. We will be back with you on the 16th of October for our next webinar, when we'll have Professor Liz Hughes from Glasgow Caledonian University talking us through the key findings from her research project on sexual assault referral centres and mental health. Lots of really important findings to share with you from that. So we hope to see you there. So thank you once again to Katherine and Emma, and thank you all for joining us. It's been a great event. Bye.